One thing you may remember from 2020 is hearing lots of things about the coronavirus pandemic. And you heard these things in different contexts from different sources, from medical professionals, political leaders, on social media, religious leaders, and so on. The majority of what most people know about the pandemic, for example, about the efficacy of masks, mechanisms of disease transmission, and procedures to guard against infection, is learned from other people as opposed to personal experience. Social learning, or the acquisition of information from others, is notoriously prone to error because it involves trust. Successful learners need to engage in epistemic vigilance, the cognitive processes of evaluation and scrutiny that individuals and communities use to determine whether to trust or distrust a given testimony based on its source and content. The specific information evaluation criteria, as well as the overall propensity to trust or distrust, are likely to play a role in how information and misinformation spread. Unfortunately, there are plenty of reasons to be pessimistic. This pandemic has been double-named a pandemic of misinformation. Numerous factors contribute to the spread of misinformation, including motivated cognition, formation of echo chambers, especially online, and influential figures swaying people's opinions away from scientific consensus. Moreover, a pandemic of a deadly disease is a scary thing, and according to several influential proposals, information about threats and hazards can be processed differently. Because it's so relevant and the costs of not believing a true claim about a threat are so high, people may have lowered thresholds and believe such information more indiscriminately. An ongoing pandemic, a universally relevant, widely discussed and contested topic, is a revealing context to examine epistemic vigilance in action. When people have to sort through a sea of potentially relevant but often conflicting information, if they selectively endorse accurate beliefs, that can be taken as evidence of well-tuned epistemic vigilance processes reflecting a balance between being overly trustful and being overly skeptical. We examined factors influencing people's endorsement of realistic statements related to the pandemic, focusing on three classes of factors that theorists of cultural transmission identified as relevant to the uptake and spread of information: information content, its source, its recipient, and the relationship between the recipient and the source. We found a variety of real statements that were indeed made about the coronavirus. Some were true, and some were false. Some asserted facts, some made recommendations on what to do or not to do. And we took these real claims and asked participants to rate how confident they were that each claim was true or false. We attributed these claims to different sources. For example, we said that this claim was made by a doctor, this was posted on social media, this one was made by a political leader. This was experimentally manipulated. That is, we ignored who said what in reality and stipulated for participants where each claim came from. Importantly, all the claims rotated through every possible source across participants. In total, we had 6 sources: medical doctor, a political leader representing a political party that the participant identified with, a political leader of the opposition party, a religious leader, either representing the religion that the participant subscribes to or the dominant religion of their region, or a statement posted on social media. We additionally had a baseline condition without a specified source, which we call sourceless. The political and religious leaders were customized for each participant based on the information they provided. We also measured individual-level descriptors for each participant, for example, perceived threat from the pandemic, endorsement of science, political orientation, religiosity, and so on. And we used these measures to predict responses. With this design, we aim to examine whether some sources, such as doctors and political leaders, are deemed universally trustworthy, whether the capacity to discriminate true and false claims varied across sources, and whether these effects were moderated by individual-level attributes. Early in the course of the pandemic, we recruited 1,791 participants from 6 countries with varying levels of pandemic severity. We classified the US, Ecuador, and Spain as relatively high in terms of pandemic severity at the time, and New Zealand, Germany, and Sweden as relatively low. Our classification of countries was confirmed by participants' subjective ratings. People in the US, Ecuador, and Spain reported feeling more personally threatened by the pandemic on average, although there was a lot of variability, as you can see. Other more objective measures of pandemic impact, such as self-reported loss of a job, also followed this pattern. We originally gathered over 100 claims from CDC, World Health Organization, and other sources, including social media, and claims of international authority figures, such as presidents and health ministers of several countries, and celebrities. These were fact-checked against official guidelines and independent fact-checking services. After we dropped duplicates, contradictory statement cases where evidence was not clear at the time, we ended up with 36 statements that covered many diverse topics related to COVID, half in the form of an assertion, what we'll call fact for brevity, and half in the form of a prescription. Basically, half said this is how things are, and half say this is what you should do. True versus false are shorthand for supported versus not supported by the evidence at the time. As a control, we included some non-COVID medical facts and prescriptions that generally went through the same selection procedure. Participants evaluated all 36 claims, each attributed to one of the 5 sources or without a source. We asked both for the confidence that the statements were true or false and a subjective change in confidence due to the source. But today I'll only focus on the first measure, and I'm happy to answer questions about the other one. On to the results. First, let's look at the effects of statement truth and type. This graph summarizes the accuracy of discriminating true from false statements as the odds ratio of giving a higher rating for true claims than false. The black dots are point estimates, and the red area is the posterior probability distribution. From top to bottom, you see COVID prescriptions, COVID facts, and non-COVID claims. All of these distributions are positioned to the right from 1, so people were reliably discriminating between true and false claims, and they were best at it for COVID prescriptions. Participants were 13 times more likely to give a higher rating to a true COVID prescription than a false one. So that's pretty good. And it's also not entirely surprising, given that COVID prescriptions are most relevant for survival. Now, turning to the effect of source. Overall, we are also getting good news here. This time, we are looking at the odds ratio of giving high response for each source compared to the average of all other sources. The key takeaway here is people trust what doctors say, at least about the COVID pandemic. And this boost comes specifically from the source. Remember, we rotated claims through all the sources, so across participants, the exact same pool of claims got rated for each source. This pattern of favoring doctors' claims held across all statement types, true and false. Moving on to participants' characteristics. For the sake of brevity, I'll just highlight the most interesting patterns we found. People who said they valued science a lot and were willing to have their tax dollars go to science funding, they attributed extra credibility to claims coming from a medical doctor and overall were more accurate in their judgments. They rated true claims as true and false claims as false. High religiosity was associated with an increased trust in pandemic information coming from a religious leader. More religious participants were also more likely to trust false claims about COVID. People who reported a strong sense of identification with any political party were more likely to trust medical claims coming from a political leader of that party. Finally, political conservatism was associated with trusting false claims about the pandemic, and this effect held across statement types and sources. Finally, we examined whether people's trust varied as a function of how personally threatened they felt by the pandemic. It did. Those who felt more threatened were more likely to rate statements as true. So let me orient you to this busy graph that shows this. So on the x-axis in this small panel, you're seeing the truth rating. So going from left to right corresponds from being more sure that the claim is true. And on the y-axis is the proportion of people giving that rating. And you can see that for the false statements, the solid line, 40% of people said sure it's false. And very few said sure it's true. So the line kind of slopes down. And we see the opposite trend for true statements. It peaks on the right, so most people say, I'm sure it's true. The panels, going from left to right, break down the sample based on how threatened people felt by the pandemic. This panel only shows people who didn't really feel personally threatened. As we go to higher threat levels, we see that the true and false lines diverge even more, suggesting better discrimination, and it's driven by better detection of true claims. Now, these are just the prescriptions, and here are the rest of the statements. The basic effect is there for all of them, although not as pronounced. In sum, those who felt more threatened were more likely to rate statements as true, and the effect was more pronounced for true COVID prescriptions than for the other statement types, whether true or false. Interestingly, we also saw that the high-threat countries were overall more trusting, or gullible if you like. But this effect was driven by the US and Ecuador. Obviously, there are countless differences between countries, and we can't say what's responsible for it. These countries, for example, were also outliers in terms of religiosity, but the effect holds controlling for individual religiosity. So this doesn't rule out the impact of country-level religiosity, but makes that story less likely, or at least shows that the mechanism is not straightforward, if it's there. Then, maybe tendency to believe false statements could be somehow related to why pandemics spread more quickly in some places early on, because people weren't as good at following precautions. Again, we cannot pinpoint the exact nature of this connection. So to summarize, our findings suggest that people were generally epistemically vigilant. Even though the information about coronavirus was highly politicized and contested, people were good at distinguishing true from false claims, especially at identifying true recommendations on how to behave during the pandemic, suggesting that they were indeed tracking medical consensus at the time and were particularly focused on actionable information about what to do. Our findings are somewhat surprising, at least they were to us, in light of prior literature on how information and misinformation spread, and in light of the alarm over the misinformation pandemic related to COVID-19 in particular. Another good news is that doctors were the most trusted source overall. It looks like during this emergency, people were properly epistemically vigilant, at least for this set of participants and materials. That said, we did find evidence of small biasing effects acting on top of overall accurate epistemic evaluations. While science fans giving extra trust to doctors about an infectious disease is not a bad thing, strong religious or political affiliation were associated with trusting figures of authority who were not experts in the medical domain, which is more concerning especially in countries where politicians from different fractions disagree on matters of science, such as deadliness of COVID. This generally shows a downside of epistemic trust when people trust experts who are not necessarily appropriate to a particular domain. We also found, as expected, that perceived personal threat from the pandemic influenced people's epistemic vigilance, but in a different way than we expected. People's self-rated risk actually increased relative endorsement of true prescriptions. This was in contrast to our original pessimistic prediction that threat would in general give a stronger credibility boost to false statements. It is not straightforward how our pattern of results could be reconciled with theories that argue that asymmetries in the costs and benefits of credulity towards hazardous information bias people towards believing all threat-relevant information. In contrast, people under threat may be particularly motivated to distinguish between actionable information and misinformation. Thank you on behalf of our team, and we look forward to hearing your thoughts and questions.